Hello, this is Clinton Power here from the Mind Body Training Institute, and it's my great pleasure to be speaking today with Doug Braun Harvey and Michael Vigorito, who are both psychotherapists and co-authors of the book Treating Out of Control Sexual Behavior, Rethinking Sex Addiction. Hello, Doug and Michael. Welcome. How are you today?
Hey, Clinton. It's good to see you.
Doing well, thank you, and thank you for the invitation to be here.
This is such a great pleasure for me because I've been reading your book voraciously, and your book, Treating Out of Control Sexual Behavior, really is, I think it has to be a Bible for anyone who is working in this field of sex therapy, and particularly if they're working with men. So I really want to dive in deep about some of the concepts and ideas in your book. And we have many therapists who are watching this interview or listening to this interview, so hopefully we'll pique their interest in your perspective, a very unique and interesting perspective on this important topic. But to begin with, tell us, how did you each become to be interested in working in the field of sexuality?
Well, I'm the old timer in the room, so I'll start, Michael.
Okay.
I actually, in the late '80s, in San Diego, there were underground vice operations going on where they were entrapping men who were having sex with men in public places, with police officers enticing them into sexual contact and then arresting them in a brutally humiliating and quite devastating consequence for men. And I was having men come to me in my private practice in the fallout of this, and it was horrible what they were going through. But they were court-ordered as a result of this public sex activity with consensual men in public places to go to sex addiction treatment programs. And in the sex addiction treatment programs, they were sitting in rooms with men who were also involved in non-consensual sexual offenses with minors, exhibiting a frauderage, much more invasive and non-consensual activity. And these men who were having consensual adult activity just because it was in a public place were deemed sex addicts by the court and had to actually go to sex addiction treatment to fulfill their legal requirements for the arrest. And I found this appalling, and I encouraged the court, and they agreed to let me be the therapy requirement for this offense. And so it was primarily, obviously gay men, and they were coming to me and did not have to go through the humiliating experience of sitting with sex offenders to fulfill the court requirement. And out of this came my understanding of that there was actually men who were struggling with out of control sexual behavior that didn't meet or really comply with this addiction model at all. And through the early 90s and 90s, sort of conceptualizing this in a variety of ways, and then deciding to make it my kind of full-time work by the mid-1990s. And I've been doing that ever since.
Well, that's extraordinary, and I hope that doesn't happen anymore with the law enforcement.
It was a horrible situation. It really was. And it's since resolved. That kind of brutality with the police has gone by the wayside, and there's not that kind of harassment anymore going on.
Yes. And how about you, Michael? How did you become interested in sexuality?
Well, mine was through my interest in working in HIV. Kind of early in my education, I was inspired to help people overcome the obstacles of care that they faced because they were a sexual minority trying to receive treatment, or because their sexual expression was considered unconventional or was stigmatized. So I wanted to help men in particular maintain their sexual health. And then within my work with HIV, I was finding there was like a subpopulation that they were reporting that they were feeling out of control, even though they had experienced a pretty significant negative consequence, which was becoming infected with HIV. So being early in my career, I was trying to figure out what's kind of the best way to help them. So I turned into the literature, and the dominant paradigm was around sex addiction. And I was finding that the sex addiction model could overly pathologize gay men's sexual interests or kind of just adjustment symptoms to coming out and calling that an addiction. And I was like, well, that doesn't seem right. So I pivoted out of that and was looking for another way of helping men address their sexual concerns and help regain sexual control. So my introduction into working with out-of-control sexual behavior all came through working with HIV and mental health.
Wonderful. And Doug, I think you've touched on something really important there, is that this term of sex addiction is something that is thrown about in popular media, even amongst therapists, which is quite scary. And it seems like anything that's considered outside of the norm today is suddenly brandished with this term of sex addiction. And so I'd love to hear your perspective on that, but maybe to begin with, how do you define out-of-control sexual behavior?
Well, the thing I like about that question is Michael and I had to ask ourselves that question.
Agreed.
We were using this term, and it's like, all right, what are we saying? And it was a collaborative discussion between Michael and I. It really, how we think about it really came out of our relationship and our working together for many years. And I think some of the key parts of how we define it, first of all, it's a felt sense by the individual. It's the person themselves has sort of a feeling, a sort of a felt sense of being out of control. And it can revolve around either their kind of urges, their sexual thoughts, their sexual behaviors. But I think a central idea to our definition is that it's a self-determined experience of the individual rather than externally defined parameters of behavior.
Yeah, we like to call it a sexual health problem. So it's in this uncomfortable diagnostic gray zone, on the kind of the spectrum of worries, problems, and disorders. It's not recognized as a disorder because the scientific consensus has not crystallized around that. So it's in this uncomfortable zone of being a sexual problem, and we like to talk about it as a human behavior problem, and all the factors that go into or contribute to human behavior problems.
And do we have any research on how many men are struggling with out-of-control sexual behaviors?
Well, there's papers published, but I don't know if I would call it useful information.
Well, and yeah, I was going to say it's difficult to say because since we're not dealing with a discrete sexual disorder, it's challenging to count, right? We can identify people seeking treatment for major depressive disorder or bipolar disorder, ADD, but because we are looking at a sexual problem and we see this as more of a subjective experience, there are a variety of factors that are involved. So it could be a symptom of a psychiatric disorder, it could be the result of a substance use disorder, but it also could be a result of overly restrictive sexual values or difficulties with sexual self-control. So the idea is that because it's more of that subjective experience, we want to make certain that we can be curious about all the different ways in which someone could feel sexually out of control. So that makes it a little difficult to count in a sense.
And I think I'd add to that there, at least here in the United States, there's a great appeal to coalescing all of the various ways people can have out-of-control sexual behavior under a very simple and neat and tidy name that has great consumer appeal. And the sex addiction name fits all of that. You can say it and people have this ready-made idea what you're saying. It organizes the experience in kind of a readily kind of understood manner. And it has great appeal. So if you're trying to quantify the frequency or the amount of sex addiction here in the United States, you also have to take into consideration all of the number of families and couples and spouses who really, this name appeals to them a great deal because it helps kind of calm the fears associated with, these sexual behaviors they don't understand.
That's such a great point, and you're making there, Doug. One of the things I've seen is that, I love your perspective, first of all, that you're focusing on the individual and their subjective experience. So if they come into our office and they talk about a struggle or a compulsion or something they're really having a difficult time with, we go with that as opposed to the therapist applying the label of sex addiction. And that's what I find particularly scary in these treatment centres as well, is that they will diagnose someone with this term sex addiction and suddenly there's a lot of moral and it's a very heavy moral judgment and it's a value-laden judgment that's applied to that. How have you I know this is such a controversial area, but where is your current stance on even the people diagnosing sex addiction, saying you have sex addiction?
Oh, there's a lot of ways we can go with this. I take a pragmatic approach, number one, in that sex addiction or hypersexual behavior or sexual impulsivity are not recognized in the DSM. So it's not a diagnosis that can be used, can't be billed for insurances. It's not something that organizes my treatment plan. But I'm also concerned if we start using that label, we can prevent curiosity. So if we use this label that assumes an etiological mechanism, then we can just like move on and provide treatment. But we want to be able to slow that down so we can get underneath the label, which we consider at times is just being used as a metaphor to describe at times I feel out of control. So as long as we can preserve that space of curiosity so we can get a sense of what's happening for the client, that to me is the priority. And I find that label can sometimes conceal more than it reveals.
Yes, we talk about that in our book, that labels conceal more than they reveal. I think I'd want to maybe do a little bit of historical, just kind of tip of the hat to the sex addiction, formulation. And that is that, in the 80s, when people were beginning to have concerns about sexual behavior control with HIV, the emergence of, the gay rights movement in a much more visible way, and the sexual freedom and liberation movement, regulating sexual behavior became much more of a kind of a cultural issue to be addressed. And when it coincided with HIV, there were a lot of fears. And the sex therapy field and the mental health field here in the United States really washed their hands of these particular behavior concerns. There was not a movement to try to help or understand this population within those professional fields. And so the sex addiction field really kind of emerged out of a void that nobody else was really willing to take responsibility to address and help people. And so it had a time that it was a very, I wouldn't be sitting here if the sex addiction field had not emerged out of the void. But I think it's a configuration that has held rigidly and strongly to a narrative that over time became less and less sexologically informed. In the United States, to be a certified sex addiction therapist requires no advanced training in human sexuality. And the entire coursework for becoming a certified sex addiction therapy doesn't even have any coursework in human sexuality. And so, I think the field has developed in a much more trauma narrative and now a neurobiological, basis of, a brain kind of addiction theory of changes in the brain based on addictive processes and disruptions in reward systems and a variety of things like that. But the field has really never embraced an integrated knowledge of human sexuality and an emerging field of our understanding of human sexuality over the last 30 years. And so they've really kind of left themselves out of the more relevant conversation in human sexual behavior in 2016.
Can I add something to that? And I think Doug is right, that we want to acknowledge that the sex addiction field is able to start this conversation, but we also like to talk about how, looking at men in the United States, sometimes we say that they only have access to therapy to talk about sexual problems as if they've committed a sex offense, if they've been sexually abused, or if they self-identify as a sex addict. So our hope is we want to be able to expand how men can receive treatment so they don't need to adopt a diagnostic sounding label and identity in order to access care. So we want to help kind of expand.
Or even access, not even necessarily care, but access somebody who's interested in helping them with their sexual health without having to first be across a threshold of a disorder. And that's why we really like to think of our responses to men's concern with feeling out of control in their sexual behaviors. We're first and foremost interested in their vision of sexual health. That's really one of the first questions we ask men when they walk in the door. Well, what's your vision of sexual health, and how come it's not happening? rather than let's find out if you have a disorder and ameliorate it and make you feel like you have to treat it the rest of your life or it'll come back.
Great points there. And one of the things I've recently become aware of are these kind of sex addiction assessment tools. And given that we're focusing on the subjective experience of our client, we're wanting to hear about their distress and be informed by their idea of sexual health, is it possible to assess in this field for out of control sexual behaviors? And where do you stand on these sex addiction assessment tools?
Well, one of the things about our model, and I think Michael can comment on this as well, is the difference between sexual values systems. There's a whole way of understanding sexual value systems from an act-centered set of values where the actual behaviors, actions, observable, kind of human behavior of sex acts is valued or judged on some sort of value system, so that let's say a man having sexual intercourse and anal intercourse with another man is judged as immoral in certain kind of standards. That's an act-centered value system. And then we borrowed this from research, really looking more from a relationship-centered value system, but we adapted the word a relationship-centered, Bill Staten's work, to principle-centered. And so our model is more about approaching sexuality not from which sex acts you engage in, but aligning a certain set of sexual health principles to guide and rudder behavior. It's a way to send you in a direction. So is your sexual behavior always consensual? Is it non-exploitive? Does it have a degree of honesty you can feel good about? Are there values between you and the sexual partners that have common ground and meaning for how you're engaging in sex with each other? Is pleasure a significant focus of the sexual act, not only for yourself, but for the people in which you're having sex with? And are you protecting yourself against negative consequences such as HIV, STIs, and unplanned pregnancy? And so those become the principles to guide sexual behavior rather than being overly focused on the acts that someone engages in. Now, why I went through all of this is the sexual addiction screening measures are so act-centered. It's all about, do you purchase sex in this way? Do you have sex with this person in this sex act? Do you have sex, with this partner selection? And it's all about sex acts. And so, I think that's the biggest thing my biggest criticism of all of their assessment measures is the heavy-handed focus on the kind of actual sexual acts and behaviors that a person's engaging in as the determinant for a disorder.
Mm-hmm. And I would add and kind of pivot a little bit and just talk about our assessment, if you like, that can kind of clarify. And one, I don't know if we mentioned this early on, that when we're talking about out of control sexual behavior, we are just talking about consensual sexual behaviors. Doug and I are pretty clear that it's a thinking error to merge these two populations. So and that the factors that contribute to non-consensual sex are likely going to be different than the factors that are present for someone who's engaging in consensual sex. So if we have someone who's presenting with something non-consensual, we make a recommendation to a non-consensual sexual specialist to address those issues. So that's kind of one of the first things that we screen for. And then we just take a look at, common ways in which sex can be dysregulated. So there are a couple of vulnerability factors like untreated or undertreated mental illness, untreated or undertreated substance use problems. But we also want to know about their medical health. Are they in some type of violent home situation with domestic violence or intimate partner violence, thoughts of suicide, cutting ways that can just dysregulate someone internally. And then once we kind of understand those acute issues, we move into a more detailed assessment, which can be between 4 to 8 sessions, combination of clinical interview and some standardized measures to develop a comprehensive clinical picture. So we're trying to find all the various ways in which people can feel out of control. It's one of the reasons why the assessment takes so long is because we want to be able to both gather information, but also process the information that comes up. Because particularly we work from a motivational interviewing perspective, so we once we find internal conflicts and ambivalence, we want to slow those down and process the emotions that are happening to help motivate them towards sexual health. So it's both kind of an information gathering and kind of treatment focus in that process.
I think I'd add one more thing to that, Michael,
Sure.
and that is that because our assessment is done in a sort of semi-qualitative interview style, so that the process of gathering this information through different measures and interview isn't just a way for us to understand the client, but it's a collaborative exchange for the client to also understand themselves. And so the process of the assessment in and of itself becomes a meaningful experience for the client, whereas most times assessments are the client passively providing information that sort of is for the benefit of the provider to sort of, direct direction of care. And our model is a much more collaborative, collective. We're going to try to figure this out together from your perspective with a certain lens in which we understand behavior. But I think the collaborative, if people were to watch our assessment interviews, they'd see how collaborative and lively the exchange is between ourselves and our clients.
And we're trying to develop a shared understanding.
Yes.
I was thinking one of the challenges perhaps for some therapists working in this field is it does require a lot from the therapist in terms of being able to really reflect on their own values, their own beliefs, their own experiences, their personal history, because there is this danger, as you're referring to, Doug and Michael, that we can start to focus on acts, we can start to focus on assessment of behaviors as moral or immoral or too much, and I think that's a real danger. And I know something I feel very sad about is many clients I've worked with over the years have had therapist experiences that have been very disappointing in that way, that they've either been labelled or judged or somehow told this is wrong and you need to do something about it, and this is the course of action or treatment. And of course, our clients don't have any other information to go along with. I'd like to hear just briefly from each of you, what are your thoughts on how therapists can approach this field and really work effectively, and what do they need to look at within themselves to make sure they're effective in working with out of control sexual behavior?
I think the first thing I would say is to have empathy and compassion for mental health professionals. I would ask them to look at their training and education. What does their licensure expect of them? What is the supervision of their training expected of them over the years? The mental health settings they work in, what's expected of them? And if we look at the entire system, expectations of sexual literacy is not a high standard in almost every level of mental health care delivery, at least here in the United States. Somebody can be a highly accomplished psychotherapist and not be necessarily sexually literate and be well respected and actually even propose very eloquent and important theories of care that the sexuality element is really left out. So we're all in this together. I think for any therapist to kind of overly attribute their lack of literacy and comfort with discussing sexuality is overly focused on their own personal failing is much like we do with our clients. Men live in a world where sexual health is not taught and understood and valued amongst men to understand. So they only get attention when things don't work well. I think that's the same thing with therapists. They only get attention for their sexual literacy problems when it's not working well. Rather than addressing sexual literacy amongst the mental health professionals systemically from the beginning in an ongoing way. So that's the first thing I would say to any therapist is, rather than sit there and be focused on regretting what you don't know and criticizing yourself and being judgmental about what you don't know, have some compassion for yourself. And, maybe if you're listening to this video, good for you. I hope you learned something, and maybe it'll spur you to read something or go and talk to a colleague. And we need to talk to each other about what we don't know about sex without being judgmental and without being smug if you happen to know a lot about sex. That would be the first thing I'd say.
And that's actually the first place we start in our book, is talking about how do therapists prepare to do this work. And we spend a considerable amount of time talking about how to improve your comfort with having sexual health conversations. So I think it's two parts have to be present. You have to increase your knowledge around sexuality, but if you aren't comfortable talking about it, you could have had, read a complete library on sex. You're still not going to engage in a sexual health conversation with your client. You're still going to avoid conversations that make you uncomfortable or steer the conversation toward the parts of the conversation that you do feel comfortable in. So for therapists to be able to initiate these conversations, their preparation needs to have a process to help them identify where they feel uncomfortable and bringing that to their supervision or consultation to work through it so they can be fully present with their clients. We work from a fairly person-centered approach, so anything that's going to create discord between us and our clients, we want to avoid. So our own personal judgments around sex, discomfort is going to interrupt that therapeutic rapport. So we help our therapists identify where they're uncomfortable and give them a path to be able to resolve that.
We also think the field suffers tremendously from what we call premature evaluation, where therapists who feel uncomfortable discussing sexuality or have little training in discussing sexuality move quickly to evaluative labels because the label shortens the need to have in-depth discussions that might be uncomfortable and to actually go into the details of human sexual behavior or actions or fantasies or desires or turn-ons or arousers that the therapist may have little experience talking about and may even feel disgust in having a person in the room who feels a desire for such pleasures. And so the labels really help the therapist sometimes avoid really complex discussions that need to be slowly, carefully, and compassionately unfolded.
That's one of the things I found about your book that was so helpful for me because I thought I was very comfortable having conversations about sexual health and sexual issues with the clients, but I realized that there were areas I was very subtly moving away from, or I just wasn't going deep enough. And your book really helped me address those. And what I found is actually being able to move into some of those very challenging conversations actually creates more safety for the client. And I think they feel more held and they actually want to talk about these things. So we need to be courageous as therapists in opening up these conversations and normalizing them as well.
Oh, okay, Clinton. So now you're going to experience how Michael and I train. Clinton, can you be more specific? Can you find one area of the book, one specific thing you read that you were glad it was in the book because it helped you reflect on something you've avoided being more direct about with your clients? I think you need to model what this sounds like for your listeners for them to do the same thing. So are you willing to just kind of share just one thing about yourself that you found interesting? I mean, you don't have to, but I just think this is how it works. We have to see each other do this work.
One of the areas which I thought I was very open about was talking about sexual fantasies. But I hadn't realized that actually sometimes when I have a client that maybe has fantasies that are closer to mine, that I may actually start to avoid them to avoid my own discomfort about discussing something that might be an erotic turn on for me. And it was something I was not aware of, that I was very subtly moving the client away. Let's not talk about that because that's something that's kind of a bit too close to the bone for me.
Mm-hmm.
Yeah.
No, and I really appreciate you saying that.
Yeah, I thank you for doing that. And I think that is such a great example because we can just talk about discomfort, but discomfort is really not an emotion. It's a judgment of an emotion, right? And so it could be a variety of things. Doug mentioned disgust. I think I talked about shame, but there's also on the other side of the spectrum when we feel turned on or a pleasurable thing that is distracting us from the moment and not allowing us to be present with our clients. So yes, I think that is a tremendously excellent example of the things that we try to help our therapists work through.
Great. Thank you for putting me on the spot there.
So then what was that like for us to ask you to do this, Clinton? Because that would just be another element to add to the discussion here that therapists often have to experience. What was that like to just be invited and just to discuss it?
Yeah. So initially challenged and nervous, and then I felt excited and energized from sharing that with you.
Yes. Clinton, that sequence right there we hear over and over again with our clients. They'll sit in group. This is often in group where they'll sit in group, and you can hear the vague speech, or you can hear the kind of narrative of the plot line, but not the character story. And so we listen for that. And so what you just saw us do is what we do with our clients. We'll gently invite them. We don't implicitly demand it, but we just say, here that we find this helps if we can do this. And then they go into the detail, and they might say something very specific. That I love prostate massage. I like being peed on. I like handcuffs, or and they've never really said these things out loud. They don't even feel their cheek muscles say these things witnessed by another human being before, and they get to have that embodied experience. And then after they've had the experience in group, we'll talk about what it was like to have the discussion. And the sequence you described is so often what it has. It's trepidation, it's worry, it's projection, it's fear, and then it's such relief. And feeling so comfortable with being seen. And men need to have this experience over and over again with other men. And it's so transformative and helpful for them. And so I appreciate you for whatever the listener saw in this exchange. This is an example of what we do with the men we work with.
Mm-hmm. Fantastic. Now, can you talk about your sexual health plan, this part of your model, which I just thought was so wonderful? Tell our listeners and viewers a bit more about how you integrate a sexual health plan as part of the treatment process.
Sure. If you want, I can pick this one up because it's kind of moving the conversation I had about the assessment along. So after the assessment is complete, we summarize all that information, and we come back to the client to review their clinical picture. As I mentioned, we want to make sure that this is a collaborative experience, and we have a shared understanding of their clinical picture, that there's nothing in there that feels off, that it resonates with them. So we want to take their clinical picture and develop a sexual health plan. So we take the answer to that original question of what is your vision of sexual health, and then we look at the clinical picture to find out what were the obstacles to achieve their sexual health, and then together with the client we create their sexual health plan. And the plan itself, to be concrete, is got 3 columns: boundaries, ambivalence, and another column called health. So the boundaries are the things that they don't want to do, health are the things they do want to do, and then we save room and welcome their ambivalence for the things that they don't feel ready to change right now. And we go through this in another session, just kind of walk through what they want to stop doing and get very specific. We want to make sure it's a reasonable plan for them to address. And then we want to find out what can we do to help support that change. And that's what the health column is for. So that is our sexual health plan.
Wonderful.
And the sexual health plan is in combination. That's the man's vision of sexual health. That's really a central tool for them to define their personal vision of sexual health, is what we call it. But secondly is that all these sexual health plans are founded upon the idea that the only thing we actually ask the men to align with in working with us is to align with a treatment frame perspective of these 6 principles of sexual health. That if you're going to work with us and we're going to work on your vision of sexual health, the assumption is you agree with us that human sexual behavior should be consensual, non-exploitive, have a high degree of honesty when necessary, shared values, be focused on pleasure, and be protected from the negative consequences such as HIV, pregnancy, and
the STI,
sexually transmitted infections. Mm-hmm. Yeah. So that's the framework. So this whole vision of sexual health sort of is understood to be sort of contained within those boundaries. So whenever they're looking at their sexual health, they may have a boundary crossing around a principle of sexual health, but they may be well within the boundaries of the sexual health principles, but maybe cross a boundary within their personal vision of sexual health. So there's several kind of boundaries we're keeping an eye on for them to maintain their sexual health.
Yeah, like another way of saying this, like once they're within the principles of sexual health, the details of their sexual plan are up to them. So these are the commitments that they're making to themselves, that they're ready to make this commitment, and that's when they put it down on paper. But then how we use that, I think, is also important to mention, is that there's a concept of accountability that we implement. So once they create their sexual health plan, they're committing to agree to these boundaries, but they're also then committing to disclose to either group and individual therapy whenever they cross that boundary at the next session. So it's common that many of these men have come to therapy because they have not been honoring their relationship commitments or have made promises to themselves to stop this behavior, whatever that might be, but keep dishonoring it. So we want to kind of recreate that situation so they can bring in those symptoms to therapy. So what happens when they cross their sexual health plan, but they don't come in to tell us the next time? What a great opportunity to deconstruct what happened and what their kind of either avoidant behaviors were attempting to solve. What were they trying to manage? So we want to kind of utilize that treatment agreement to welcome that symptom into the room so we can raise their awareness around it and try to figure out and unpack what was happening.
I just want to add one more thing, Clinton, to that. And that is implicit in all of this, and we haven't said it yet, and that's why I want to say it. These are all the systems we put in place in the work we do with men to uphold our ethical stance, which the first ethical stance we have in this work is actually to protect the client from us. And that's kind of what, how we got into all of this, what happens when therapists have all their values and judgments. And so this part of our treatment and the planning of the sexual health plan is really to try to protect the client as much as we possibly can from the therapist's biases and values overly influencing the client's own choices as to how they want to live their life.
I was going to say, just to give a little more detail on that, is particularly around the sexual health principles as a way that we use to evaluate when we're going to intervene. And those principles come from the World Health Organization's definition around sexual health. So it's not like these are principles that two guys from California just created and said, hey, everyone follow this. This comes out of a consensus of public health professionals and medical professionals in their work and trying to understand what sexual health is. And then we took those principles from that definition to apply them to psychotherapy.
And I think that's so powerful for our clients and patients to be formulating this in collaboration with us, because again, it's coming from the client. And of course, when they're enrolling in those ideas and that vision, it's going to be so much more powerful than us externally imposing some other set of values or behaviors, which seems, from my point of view, to be coming from the sex addiction and treatment model and addiction centers, is they seem to be imposing this is the way you should be and you need to conform to this kind of structure.
Yeah, and that's what we call it. It's a contradiction that we want to get curious about. It's interesting. You made this commitment, but you crossed it. That's an interesting contradiction. Let's learn more about this thing. And that is usually how we approach that conversation.
Rather than a relapse in your addiction.
And kind of threatening your participation in group. No, we welcome that conversation, and that's part of the work.
That's the message I just love in your book, Treating Out of Control Sexual Behavior. It is sex positive. It's about sexual health. It's about being in relationship with clients and supporting them in their vision of sexual health. And tell us a bit about what has been the response to your book, because from my perspective, I think this is a seminal book in our field. And I'm imagining this needs to be required reading in all psychotherapy training across the world. But what is the response you've had so far?
You probably know more about that than us. We walk into rooms and, somebody has our book and like, how did you find it? It's an interesting thing when you write a book, you just sort of put it out into the world and it has a life of its own. We're much more disconnected from our book now that we're done writing it. So we learn about how people feel about our book by meeting people who've read it and say the things like you just said, or we get emails from people who said, I've read your book, or more recently, we've been getting stories from therapists with clients walking into the therapy room with the client having purchased our book. Because the client reads the description on Amazon or whatever, or Springer Publishing Company, Inc., which published our book, and likes what they read, and they think it's for them. And then they buy it and they see it's a book for their therapist, not for them. And so therapists have told us this story, and so Michael and I are just beginning the task of beginning to write a book now for clients or for the general public on these same principles. But it's been out for less than a year, and the fact that we're doing an interview with you in Sydney, Australia, says something about what's happening with this book. And I don't know what it says, Clinton, but it says something.
Great. Wonderful. Now, where can people get your book? Amazon, obviously, it's in paperback and Kindle.
Correct. Yeah, they can get a copy from the publisher, Springer Publishing, but also Amazon, Powell's Books. It's linked through my website, and I'm assuming also Doug's. So yeah, wherever books are sold. Online. Wherever books are sold.
If you have a local bookstore, we really love to support local bookstores. If you have a local bookstore that doesn't stock it and mental health professionals go there for books, suggest that they have that book on their shelf, because we want it to be something that's a little more accessible visually when somebody's just browsing a shelf. I think for me as a therapist, oftentimes I'm old school, but sometimes just standing there and looking at a shelf creates interest in something, and I think the subtitle of our book, which we find has been very important in people understanding and being interested in our book, is the subtitle of our book is Rethinking Sex Addiction. And I think that's really an important part of our book. Is we're just really saying, let's step back and relook at this from another perspective, without continually trying to hold on to ideas that were first promoted more than 35 years ago.
I'm very excited to hear you're collaborating again, and that there will be a book coming out at some point for the layperson. I think that will be in very high demand. For those, I know you're often doing workshops across the US. I'm not sure if you're in other countries, but where can the therapists listening and watching, where can they go to find out more about each of you?
My website is called theharveyinstitute.com. And that's actually part of the larger business my husband and I have called the Harvey Institute, where we educate and train a wide range of healthcare professionals on how to have sexual health conversations. So the work on out-of-control sexual behavior is a component of my overall commitment to improving conversations in a wide range of healthcare around sexual health. My first two books were around sexual health and drug and alcohol treatment. So I've really been very interested in improving drug and alcohol treatment professionals' ability to talk about sexual health. So that's why my website is called theharveyinstitute.com, and you can certainly get all the information you need to know about where I'm at.
And I'm also doing similar work in DC, and you can find me at iCounselingServices.com. Stands for Integrative Counseling Services, as I'm trying to help integrate mental health, substance use, and sexual health systems of care out in DC.
Wonderful. So that's iCounselingServices.com. That's counseling with one L, US spelling there.
Correct.
We use two L's down under here in Australia. I just want to say thank you so much to you, Doug and Michael, your incredible generosity in sharing this important information. And thank you for all you're doing for our field. It feels like there's an incredible groundswell that's occurring at the moment, and you're at the cutting edge, and it's great to see you riding that wave. And I really hope that this, as you say, Doug, this kind of rethinking continues in our field, because I think it's really important, and our clients are going to benefit in the long run.
Great. Thank you so much.
Thank you, Clinton. Yes, and you are bringing us to your listeners in Australia, and I think you should be applauded for bringing information to your country that is important, and people need new conversations, and it's just literally from people like you that create opportunities for who knows who's going to have listened to and watched this conversation, and which clients may have a different response from their therapist because you've provided this opportunity for the conversation. So, it's a very collaborative exchange here, and this is just an example of what we think needs to happen more.
Thank you so much. Well, an absolute pleasure to speak with you both. And for those listening and watching, just a final reminder, Doug and Michael's book is called Treating Out of Control Sexual Behavior, Rethinking Sex Addiction, at Amazon and all good bookstores. And I really hope we get to speak again sometime. It's been a real pleasure.
As do I.
Thank you.
Thank you so much.
Bye for now.